So very good afternoon to everyone and warm welcome to all the participants to this OSCE program, an initiative that Gangaram Hospital has been doing for the last few weeks. Thank you, Dr. Anupam, for organizing this. And today we have chosen pediatric hematology, oncology as the topic for OSCE. And, we'll be taking you through 25 stations, and there will be questions, and then we can discuss the answers for those 25 stations that we are going to present. They are a mixed bag of hematological and oncological problem in children, and Dr. Anupam is there, and I will be there. Both of us will be there to kind of take you through these questions, and it would be really nice if you can participate. It would be really nice if you can participate in this OSCE and give answers so that it can be an interactive session. So, sir, if it is okay with you, we can start with the stations.
Yeah, absolutely, Manas. Go ahead.
Okay, thank you. So the first question that will be coming your way is this. So we have shown you a picture of a peripheral smear, and there are questions which have been posed. The first question is, identify the abnormal cell, name 3 crises seen in this disease, and what is the name of the drug which is used to treat this disease, and what is the mechanism of action. So look at the slide and go through the questions, and maybe somebody can answer this question, and then we can discuss it. So anybody wants to go to answer this question? It's fairly easy, very simple. And actually the second question is giving you a very big hint as to what the condition is. Anybody wants to answer?
Good afternoon, sir.
Good afternoon.
Yes, please. Devesh, you want to answer?
Yes, sir. The cells seen in this picture is sickle cells.
That's right.
And crisis involve painful crisis. Second thing.
You want to name the drug? If you don't know the crisis, do you want to name the drug? Anyone else wants to answer?
Sir, acute chest syndrome.
Okay, it's a type of a crisis.
Vaso-occlusive crisis.
Okay, yeah.
And the drug is hydroxyurea.
Dr. Sandeep has also answered a vaso-occlusive crisis. So yeah, and drug is hydroxyurea. And what is the mechanism of action? Okay, so sir, do you want to talk about this?
Yeah, actually, for the postgraduates who last time in the OSCE also there was a question on sickle cell disease, and a similar sort of a picture was put, and they asked identify the cell and all. Now, when when you have a question like that, you need to know that.
I request everybody to please mute yourself when we are giving the answer. Kindly mute yourself.
Sir, please, you are requested to mute everyone, sir, from the option given in the right lower corner.
Sir, please go ahead.
Okay. Now, when you have a question like that, they may ask you like name three crises, or what are the three crises associated with it. The answer key will usually have 5 or 6 options, and if you write any of the three, you will be able to gain marks. Number 3 is that regarding hydroxyurea, for example, if we are asking you mechanism of action, we may give in the answer key 5 or 6 different mechanism of actions, or 5 or 6 options may be there. Any 2 or 3 options which you give are good enough to fetch you the full marks. So remember these things, and majority needs to know this thing, that the questions are very specific, and they are not going to be like a short answer note or anything of that sort thing in the OSCE.
So we have sickle cell, we have aplastic crisis, we have vaso-occlusive crisis, splenic sequestration crisis, hydroxyurea is the drug, stress erythropoiesis is the mechanism, it raises the HbF level, it decreases the polymerization of the sickle HBS, and that kind of helps with the rheological properties of RBC being changed. And many other minor mechanisms. It helps these patients to have better hemoglobin, better quality of life, and less of occlusive crisis. So we move on to the second question, which is identify the instrument. What are the contraindications to the procedure that it is used to do, and name 2 indications in oncology for its usage. Very fairly simple questions have been kept so that it just stimulates.
Can I come in now at this stage?
Yes.
Ideally, this would be an observed station in an OSCE where they would keep the needle and keep the instrument, and also keep other things along with it. And what they do is they observe how you do the procedure. So, so this now we are doing virtual OSCE, so it is not possible to do that. But generally, an instrument being used or an instrument being put there is an observed station. Okay? Because ultimately, when we come down to the actual OSCE, it will come as an observed station.
Yeah. So anybody would like to answer this question? Something in the chat box. LP needle, raised intraocular pressure. Somebody has written LP needle, raised intraocular pressure.
Sorry, sir. Intracranial pressure, raised intracranial pressure.
Yeah. So any other contraindications anybody wants to say? So there is some more. LP needle, contraindication, LP site infection, that's right. Bleeding disorder, which is uncontrolled, that's right. CNS manifestation of leukemia is what you want to be. Is that a contraindication? So CNS manifestation of leukemia is really not a contraindication, but actually you are doing it to identify if the CNS is involved or not. Okay, so yes, it is a LP needle. The contraindications are infection at the local site, a very severe bleeding diathesis, a raised intracranial pressure where there is chance of coning, and you want to diagnose the presence of malignant cells by doing a lumbar puncture, and you also want to give chemotherapy. So you give intrathecal chemotherapy in cases of leukemia, so that the cancer, if at all it is there, it is killed, and it doesn't really infiltrate the brain and cause long-term problems, and children can die of uncontrolled CNS disease if you don't control it. You want to avoid radiation, so you give intrathecal chemotherapy. By giving chemotherapy, you don't have to give radiation to the brain, which can have long-term side effects. So that's the idea of doing a lumbar puncture in malignancy patients. So you can do it in Leukemias, you do it in non-Hodgkin lymphoma, you do it in medulloblastoma to see if there is cancer cells, you do it in other malignant brain tumors also, like ependymoma, to see if there are cancer cells present or not. So that is your second station. We'll move on to the next station, the third station. So please read this station carefully. So we have a 7-year-old who walks into the emergency. He's a known case of sickle cell anemia. There is distress, there is tachypnea. The child looks pale. He's hypoxic. Temperature is 100.8 degrees. On inquiring the history, the parents tell that he has been having cough for the last 5 days. There's difficulty of breathing since morning. An X-ray is done on emergent basis, and it shows this kind of a picture. So you have that much time to actually read the case scenario. Please make sure that you read it carefully, because sometimes the hint is there in the question itself. Like the previous question, which mentioned crisis. So if you hear the word crisis, you know that it doesn't exist in many hematological diseases. So the hint was there. Okay. So now you have this patient. You have read the scenario, and we'll go to the questions. What is the most likely diagnosis? Name 2 specific interventions that would help in the treatment of this condition. What antibiotics would you use? Name the groups to which these antibiotics belong. So anybody would like to answer? So yes, somebody has said that it is acute chest syndrome. So that's the right answer. Specific interventions is basically specific treatment things that you do. So somebody has written blood culture and chest X-ray. The chest X-ray is already there. And then the answer given is ceftriaxone. Sir, would you like to comment on this? The blood culture chest X-ray as the specific intervention that you would do in the treating this condition?
As I said that you won't get that easy an OSCE in the exam, because the hints are there in the question itself and in the subsequent. Normally, acute chest syndrome. Hello, can you hear me?
Yes, sir. Can hear you.
Yeah. In acute chest syndrome, what we have to differentiate is, could it be a pneumonia? But there's no way we can do that immediately. So that's why we send a blood culture and we send the other investigations for infection. Along with that, we start a third generation cephalosporin, ideally like ceftriaxone. And then along with that, we can also start a macrolide to cover the atypical pneumonias also. So that is what I would do.
That's right. So it is, sir has clearly told that macrolide third generation cephalosporin would be the answer to question 3. The first question you have mentioned, it is correct, that is acute chest syndrome. I think when you talk about specific interventions, you don't have to write the investigation. We are talking about treating this child. So, you have to mention blood transfusion, because that is what is usually done in children with sickle who present with acute chest. You may give them bronchodilators, you do incentive spirometry, and non-specific measures are something like pain relief and oxygen, which is usually required for these children. And if you mention any of these, or some other common interventions that you use to treat these patients, then you will be getting full marks for this case scenario on acute chest syndrome. These are simple questions, but we often make mistakes in simple questions, and that is a place where you actually have to secure the maximum amount of marks in your OSCE. Okay, so we'll go on to the next question. That is the fourth station. So again, we need to read it carefully. So this is a 3-year-old child who presents to the OPD with fever since 2 weeks, easy fatigability since 1 week, multiple reddish spots all over the body since last 3 days. CBC shows anemia, TLC is 3,400, platelet is 80. Coulter shows neutrophils of 4%, lymphos of 89%, monos of 5%, and eosinophils of 2%. After stabilizing the child, a marrow evaluation is done to ascertain the cause. So bone marrow is done in this situation, and this is the marrow picture. So you need to identify the cell. What is the child suffering from? Name the 2 drugs that are used to treat this condition, and mention 4 differential diagnoses for this case scenario. So we now have 25 participants. We are on OSCE number 4, and I've given you the clinical scenario, and it would be really appreciated if you participate and give answers for this. Would anybody like to give the answers? So somebody has written in the chat that it is AML. Anyone else? So somebody has written lymphoblast and ALL. So this is actually acute lymphoblastic leukemia. The blasts have hardly any cytoplasm, and the child is suffering from acute lymphoblastic leukemia. The cell is lymphoblast. Mention 2 drugs that are used to treat this condition. Anybody wants to say what drugs are used to treat this condition? You all know that you must have managed some leukemia somewhere. Basic drugs that are used. See, you have to answer these questions, otherwise it is not interactive. It is a monologue. Okay, so it has to
Some
be
methotrexate
okay, good.
and
Methotrexate,
vincristine.
methotrexate, steroids, asparaginase. So these are common drugs. Daunorubicin. Prednisolone is the commonest drug. Methotrexate can be given intravenously or intrathecally. Cyclophosphamide, cytarabine, and then the maintenance comprises of 6-MP, that is 6-mercaptopurine, and methotrexate. So please, you should know these drugs. Now the question is, what are the differentials for this situation? So when the examiner is asking you differential, you can give differential on the clinical scenario. So pancytopenia you have, and you have to give differentials, and this is a child with fatigability, reddish spots. So what will be the DDs? DDs can be acute lymphoblastic leukemia. The DDs can be acute myeloid leukemia. If you don't know the marrow, it can be an aplastic anemia also. If there is organomegaly, then aplastic anemia becomes unlikely. Sometimes serious infections can lead to a DIC like picture, and you can have cytopenias associated with severe sepsis. EBV infection can lead to cytopenias, and you can see abnormal lymphocytes in EBV infection. So those are the common DDs. So HUS, what happens in HUS is you see broken cells, you see schistocytes, there is anemia, there is thrombocytopenia, but leukopenia is not that prominent. Here there is severe neutropenia. So you can see that neutrophil is only 4%. So rather than saying HUS, we would think of a marrow disorder, in this condition, because it is essentially a pancytopenia. The definition of pancytopenia comes from the neutropenia that is associated, not just the WBC count. You need to look at the neutrophil count, and if it is low, it becomes a pancytopenia if there is anemia and thrombocytopenia. So that would be the station number 4.
Somebody had written in the chat box HUS. This is not how HUS presents, So one has to be careful in making a diagnosis and don't bring in esoteric or diagnoses which are not very commonly seen. You have a patient who's got pancytopenia. So there is, first think of a condition which can cause pancytopenia rather than HUS. Like if there was something like HUS, we would mention in the OSCE that the smear code, schistocytes and all those things, we would have mentioned that.
Or we could have shown you the image of schistocytes. Okay, so we'll move on to the next one. That is the station 5. The 10-year-old male child with complaints of fever and cough since 2 months. He was put on anti-tubercular therapy by a local practitioner. He did not have improvement in his symptoms. He now has breathlessness, facial swelling since the last 2 days. There are dilated neck veins that are visible on inspecting the patient. An X-ray has been done which shows this. So often in India, all mediastinal nodes, neck nodes are treated as tuberculosis even before a diagnosis is made. That practice should not be done. We should try our best to establish a diagnosis. So in this case, clearly the ATT has not worked. And we have a child with a mediastinal widening. What is your likely diagnosis? 4 oncological conditions that can cause such an appearance in the chest X-ray, and name 3 drugs or modalities used to treat this condition. So somebody has written superior vena cava syndrome. So you are right, because these dilated neck veins are probably superior vena cava syndrome, the facial swelling. But you also need to see that the child has breathlessness. So when there is breathlessness and there are big nodes, there can be a tracheal compression as well. So when the airway is getting compressed, it becomes a superior mediastinal syndrome. And we have to tell the underlying conditions. So lymphoma has been written as one of the possibilities, which is right. So, what is the common lymphoma that leads to this in this age group? Anybody wants to mention? So Hodgkin lymphoma, someone has written. So Hodgkin lymphoma usually doesn't cause breathlessness, usually doesn't cause superior vena cava or superior mediastinal. It is more often a non-Hodgkin lymphoma. So
Sir, can it be a lymph node, enlarged lymph node?
So these are enlarged lymph nodes. You are right, Dr. Lakshya. These are enlarged lymph nodes. But what is causing this much symptoms? Breathlessness, facial swelling, dilated neck veins. So there are
Sir,
lymph
lymphoma
nodes.
maybe?
Yes. So lymphoma is the most important differential. That is what we were saying. So most often the lymphoma that causes this is a non-Hodgkin lymphoma. It is often T cell NHL. T cell non-Hodgkin lymphoma leads to compression of the airways. Rapidly progressing tumor does not respond to ATT and often misdiagnosed as tuberculosis. So Hodgkin lymphoma is usually slow growing. It can be present for months to years and, and doesn't really cause the mediastinum syndrome, although in extreme cases it can. Other conditions which can lead to mediastinal widening can be Hodgkin lymphoma, non-Hodgkin lymphoma. It can be acute lymphoblastic leukemia, just a simple ALL with mediastinal nodes. It can be in many other tumors like neuroblastoma, germ cell tumor, where you can have mediastinal widening and can present with the X-ray, something like that. Thymoma can be there. Yes, malignant thymomas can be there. Three drugs or modalities to treat this. So if you talk of NHL, BNHL or TNHL, usually it is treated like ALL. So you can just mention the same drugs like ALL, cancer. It's usually treated with chemotherapy. We don't need radiation. We don't need surgery for most of the cases. However, if it is Hodgkin lymphoma, sometimes we need radiation for our patients. Sir, do you want to add anything to this question of mediastinal mass?
I mean, I think it is very important that we realize this thing that uh, one of the key questions which I would ask in this kind of a thing is, uh, would you do a biopsy in this situation? So from the mass. Uh, so that is one thing, because we avoid a biopsy from the mass as far as possible, and we try to make the diagnosis from the peripheries, rather than, because a sudden increase in the biopsy would cause problems for the child. The other thing is, another question which should be asked is, if you are doing a marrow, what kind of or a marrow or any procedure on this patient, what precautions will you take? Again, uh, uh, avoid sedation as far as possible. Uh, Avoid putting the child, making the child lie down, because on lying down, the patient may have respiratory compromise. So these are some of the things which can be asked in this kind of an question.
I think very important points there. So don't sedate these children because your tracheal compression can be so bad and the child loses the control of his airway and you can have a cardiac arrest, respiratory arrest, and you'll not be able to intubate this patient. So that is clear message over there, and that can be another question. Avoid biopsy as much as possible. So if it is TNHL, just treat like ALL. And if it is Hodgkin lymphoma, you can write the Hodgkin drugs. So we'll go on to the sixth question. A 14-year-old male child presents who's active and playful. There is no history of trauma, no fever, was brought to emergency because he noticed these kind of spots on the legs. He's not on any chronic medication. He had a mild cough 14 days back. CBC done outside shows a hemoglobin of 12.8, a white cell count of 6,800, and a platelet of 2,000. IPF is 18.5%. Name any 2 drugs for use in acute episode. Name any 2 drugs used in the chronic condition. And name any 2 tests that are required in the chronic form. So 2 drugs used in the acute episode. So you all know it is ITP, idiopathic thrombocytopenic purpura, or the new name is immune thrombocytopenia. The very fact that the child is very well, jumping around, is playful, you know that there is probably the disease is not very severe. The platelets are drastically low. The other 2 cell lines look normal, and the immature platelet count, immature platelet fraction is high. So IPF increases when there is destruction of the platelets. But I think very important is that if you are a practitioner seeing this child, you should ask for a peripheral smear. You should ask for a differential count, a manual look at the peripheral smear, and make sure that there is nothing abnormal before you call it ITP. To name 2 drugs, somebody has written prednisolone and IVIG. If this condition becomes chronic, what are the drugs that are used? Please mention, please answer the question. Name any 2 drugs used in the chronic condition. What are the drugs used for chronic ITP? What is the 3rd drug used for acute episode? Anti-D, IV anti-D. It is not available nowadays, or available with difficulty. For chronic condition, okay, so somebody has written L-Trombopac, Romiplastim, Rituximab. So very right, all these drugs are used for chronic condition. What else? What else can be used for chronic ITP? Dapsone can be used for chronic ITP. Splenectomy is rarely used for chronic ITP, but that is one of the modalities that is available. Sometimes people use dexamethasone pulse also, but I think the drugs that have been mentioned are the drug of choice for this condition. Any 2 tests that are needed for the chronic form? What test do we do when a patient has chronic ITP? Would anybody like to mention? Give the answer for this. ANA, yes, you are very right. You want to do ANA, and because sometimes lupus or connective tissue disorders can present with chronic ITP like presentation. What else? Sir, would you like to say anything about this question?
Again, the list is huge as far as chronic form is concerned. You'd like to rule out all kinds of collagen vascular disease, like HIV, HBsAg, HCV, etc. Then also some genital immunodeficiency disorders. Although 14-year-old may usually a congenital deficiency disorder may be still you would like to do the immunoglobulin levels, etc. So number of diseases we have to rule out as the causes for a secondary ITP, and then we have to proceed ahead accordingly.
That's right. So HIV, hepatitis B, hepatitis C, ANA, immunoglobulin level, because sometimes CVID can present with ITP. These are the common conditions. People say that if you have not done a bone marrow, you can do a bone marrow. Somebody has written just a biopsy. I don't think that will be a correct answer. Just saying biopsy will not have much of a meaning. Somebody has written anti-platelet antibodies. So that anti-platelet antibody is not much of much use in ITP. It's a very non-specific test. I don't think any one of us does anti-platelet antibodies for ITP. So that doesn't have any meaning. HIV, yes, you need to do hepatitis B, hepatitis C as well. So we'll move on to the next question. So please read the question carefully and the CBC. Please read the question and we'll ask the question. We'll give the questions properly. Please read the case scenario. So you have seen this child who's 7-year-old, who's brought to your OPD. 21-year-old sibling is admitted for cholecystectomy. There is fatigue. There is history of neonatal jaundice. There is pallor. There is splenomegaly, and you have a CBC Coulter report and a peripheral smear picture. The question is, what is the mode of inheritance of this disease? And name 2 lab tests to be done for confirmation of diagnosis. Please type your answers, or you can just unmute and answer the questions. So, autosomal dominant, hereditary spherocytosis. So those are the right answers. So this is hereditary spherocytosis. Can you tell what is the peculiar thing in the CBC? What is the striking thing in the CBC? Can anybody give the answer for that? MCHC is high, that's right. So the high MCHC point towards some kind of a membrane disorder, and here we have hereditary spherocytosis. The right answer. Please mute yourself. Please mute yourself. Please mute yourself. Osmotic fragility test is the right answer to what test should be done. And what is the other test? There are 2 specific tests for this condition. The other specific test is the EMA dye binding test. An EMA dye binding test will also point towards a positive EMA dye binding test will also point towards a hereditary spherocytosis. Sometimes you don't get the osmotic fragility easily. You may have to do an incubated osmotic fragility. You can see in the peripheral smear, we are seeing these round cells. These are spherocytes. They don't have a central pallor. They are disc-like cells. Their MCV is not very high or very low. They're kind of, and there are a lot of retics. Reticulocytes are high because of the hemolysis. There is extravascular hemolysis and a lot of retics are produced. So if you do a retic count, the retic count will be high in this case. The sibling is getting operated because he also probably has this disease, and there is a early formation of gallstones in a young age. An exchange transfusion also is pointing towards a neonatal hyperbil, which happened because of the hemolysis. There is anemia, there is splenomegaly. So the triad of anemia, splenomegaly, and jaundice is what you see in these patients. So that's this OSCE for you. Now we move on to question number 8. 7-year-old child, previously asymptomatic, admitted with 3 days of jaundice and red-colored urine. There is history of burning micturition, abdominal pain is present. Please read the full case scenario. Please answer the question.
Difficult question, sir.
Hemolytic uremic syndrome.
So somebody has said Ray's syndrome.
G6pd deficiency.
Yes, so somebody has said
Hemolytic uremic syndrome. Hemolytic uremic syndrome.
sulfonamides, aspirin, HUS, HUS, HUS. Dr. Anupam, would you like to comment on this?
Sir, as bite cells can be seen, it is G6pd deficiency, most probably.
So you are right, it is classically seen, these bite cells are classically seen in G6pd deficiency. So many answers pouring in now. So people have become active and they are answering most of the questions. So that's good, that's heartening. So you can see that this child suddenly developed this red color urine, which is probably a hemoglobinuria that is happening. Then there is jaundice, which has just suddenly come up. So there is a severe intravascular kind of a hemolysis that is happening. Then there is, you can see that there is a history of cold, cough, and maybe took some medicine, and the medicine has been mentioned. So, if you think like that, the examiner is trying to point towards G6pd. Moreover, there is also question on neonatal history. So HUS is not fitting into the full scenario. It is G6pd which is fitting better in this case scenario. And then, you have the long list of drugs that you can mention in G6pd patients. So yes, so in G6pd patients.
Please
yes,
do
sir.
not confuse between schistocytes and bite cells, which quite a few people do, and be very careful about it, because usually this sort of an OSCE question would carry about 5 to 6 marks. And if you go wrong the first time round, then it will be very difficult to rectify things, and the subsequent questions which are on the on this station would also go wrong.
So this is G6pd, and you know about the drugs. Mentioning a few would be enough. You don't have to give the whole list or remember the whole list. The common ones like primaquine, trimethoprim, sulfamethoxazole. You don't want to miss those common ones that lead to hemolysis, methylene blue, and you just need to be careful about these drugs. Okay. The next is this instrument again. So we have shown you a lumbar puncture needle. The next is this needle. Identify the instrument. Mention 2 sites of doing the procedure. Name 2 indications for doing the procedure. Simple question. So it is not a bone marrow aspiration needle. It is not a bone marrow aspiration needle. It's a bone marrow biopsy needle. So what we are seeing here is a bone marrow biopsy needle, Jamshidi, typically Jamshidi needle we call it. You have this, there is a stillet in it, and you can see this instrument which is used to push the biopsy piece out from the other side so that it doesn't get crushed. Nobody has answered the other questions. 2 sites. Can you mention the 2 sites and the 2 indications? So people do it from sternum in adults, but commonly in pediatrics, we don't do it from sternum. We can do it from iliac crest. We do it from posterior superior iliac spine. We can do it from tibia. So yes, right, those points are correct. And indications are usually pancytopenia, where you're suspecting a leukemia. You're suspecting anaplastic anemia. I think aplastic anemia is a very important thing, because when you're talking about biopsy, you can diagnose leukemia just with an aspirate. But when they ask you for biopsy, you want to mention aplastic anemia, you want to mention solid tumors, because neuroblastoma, diseases like Hodgkin lymphoma, where you may have like small infiltrates of cancer. So you want a biopsy piece, a big biopsy piece, and preferably a bilateral biopsy to see if the disease is there or not. So for aplastic anemia, you definitely need a biopsy. For solid tumor infiltration, you definitely need a biopsy. But leukemia, you can just diagnose based on an aspirate, and you can run a flow on the aspirate sample. You can do karyotyping, and you can make a diagnosis. So myeloproliferative disorder, yes, it's a non-specific term, but yes, you can say that. So you should mention aplastic solid tumors. And I think, even if you say leukemia, that should be fine. Sometimes we just do an aspirate with this needle, but it is actually a biopsy needle. We can just put the needle, take an aspirate, and that will be a bone marrow aspiration. And then you can use the same needle to do a biopsy, but it's actually a biopsy needle. So that is what this question is about. And there are 5 components to it. So, you have to look at each and every component and then answer the question. So we come to the 10th question. We have an image in front of us. Identified the arrowed cells in the peripheral smear. 4 conditions where you see this. So somebody has written hypersegmented neutrophil, so that's right. Teardrop cell, so that is also right. And the other thing is a macrovellocyte. So perfect. So all 3 are correct. You are seeing macrovellocytes, you are seeing hypersegmented neutrophil, you are seeing teardrop cells. Name 4 conditions where you see this. You don't want half marks, you have to get the full marks. So B12 deficiency is correct. Megaloblastic anemia, yes, so that's correct. So folic acid, B12, both can lead to megaloblastic. Where else can you see macrocytic anemia? So you may not see all the features, but where can you see macrocytic anemia? So hemolytic anemia, you usually see hemolytic cells. So I don't think we can give hemolytic anemia as the right answer. You can give DDs of macrocytic anemia at least. So I'll show you a slide. So you can see macrocytic anemia in many conditions. You can see larger cells in aplastic anemia. You may see large RBCs in inherent bone marrow failure like Fanconi's, etc. You can see in hypothyroidism, liver disease, and these are some other rare conditions where you can see macrocytic anemia. So would you like to add anything to this question?
I mean, again, very large, you would not see these multi-lobe nuclei, neutrophils in aplastic and other conditions, except for in B12 deficiency. So that's the kind of a clincher which you have in this thing.
Somebody has written DBA. So DBA does lead to macrocytosis. Yes, you are right. For macrocytic anemia, that's a DD. All the other inherited marrow failures also usually have macrocytic anemia. So we move on to the next question. Name the arrowed entities. Two conditions where you see these arrowed entities. What other investigation would you advise with these cells in the peripheral smear? So please look at the peripheral smear carefully. Two conditions and other investigations. So I think many of you have said schistocytes and HUS. So that's the right answer. So these are broken cells. They are not really typically the bite cells and they are of different morphology. They are schistocytes typically seen in HUS or TTP. Microangiopathic hemolytic anemia is right. And these fragmented cells typically, are associated with HUS or TTP. Other investigations would you advise with these cells in PS? We want to do a kidney function test, to look at uremia present or not. You should know the pentad of TTP because that can be a question. Fever, neurological symptoms, plus the classical triad of HUS, thrombocytopenia, hemolysis, uremia. And I think this is an important question and frequently asked in OSCE. Very frequent question in OSCE. We'll move on to the next question. So this is like a counseling station. So you're being asked to counsel a family. So there is a 7-year-old child who is a known case of TDT. transfusion-dependent thalassemia on regular blood transfusion and chelation with Differentials. His weight is 20 kg. He takes 500 milligram of Differentials every day. His blood transfusion chart shows his average pre-transfusion hemoglobin is 7.5 gram percent. He was investigated, found to have ferritin of 3000. How do you counsel this family? So it's a counseling station, and there will be somebody observing your counseling. So, yes.
Sir, to maintain normal hemoglobin level more than 9.5 gram percent, we will give transfusion, and we will see for the compliance of chelation therapy also.
Very important points, very important. You would counsel for good transfusion. You'll counsel for good chelation. So always tell these families that the child needs packed red blood cells, not whole blood. Preferably use a filter to give blood transfusion and maintain pre-transfusion hemoglobin more than 9.5 or 9 at least. You may give them advice for healthy diet, protein rich diet, avoid iron supplements, and advise them to take proper chelation therapy. The chelation Differentials has to be in a proper dose. So usually to get a negative iron balance, you need 30 to 40 mg per kg per day. This is clearly not enough. So you'll have to go up on the dose. If the compliance of chelation is good, you will have to increase the dose. And you also need to make sure that they are taking the drug properly. So the drug has to be given in a glass container with a plastic spoon. You need to mix the drug with water, apple juice or orange juice, and then the patient should take it in the morning, empty stomach ideally. All these things have to be done religiously. If they don't do it, then they will have problems of anemia, they will have problems of iron overload. And you can name a few complications. And if you tell all these points in a sequential order, because, sir, is that right that the counseling station carries more marks?
Usually it carries around 10 marks. Out of 150, nearly 9 to 10 marks will be for counseling. You have to be very courteous, introduce yourself, talk to the patient that you have this problem, and now you are having this problem. And then you have to counsel accordingly. Okay. So again, your mannerisms, your way to conduct yourself in front of the patient are very, very important, because that by itself will get you another 1.5 marks extra. If your mannerisms and the way you conduct yourself with courtesy, it will, that makes a tremendous difference.
I think a very important station to gain marks, and a simple diagnosis, simple management, but it's just the way you use the tricks that have been suggested by sir. Next question is: a 6-year-old boy, poor growth. The child looks yellow. There is
Manas, I'm sorry, I'm logging off on another meeting.
Okay, sir. Sure. So 6-year-old child, poor growth, looks yellow. There is pallor. There is icterus. There is spleen. There is liver. He is evaluated outside. His doctor says that he has a liver disease. He's been started on UDCA. So some UD liver something. Wants to give him blood transfusion and evaluate. This is the CBC. So you can see indirect hyperbilirubinemia. There is anemia. The white cell count is high. MCV is low, 61. RDW is high. The retic count is a little bit high, but corrected retic may be low. The child has never been transfused, and this is the peripheral smear. Anybody would like to say what the condition this child has? What do you think this child has?
Sir, a differential diagnosis can be hemolytic uremic syndrome because the platelets are slightly on the lower side and hemoglobin is also on the lower side.
So you have a point, but you see that this is like a chronic kind of a condition with splenohepatomegaly. So HUS is an acute condition. Usually they don't have spleen and liver. And the jaundice is like, not that marked because it's an intravascular hemolysis that is happening in HUS. So here you can see that the spleen is probably the reason why there is thrombocytopenia. So spleen is destroying the platelets in this condition. Somebody has mentioned thalassemia, you are right, but you will not get marks if you say thalassemia. You have to mention thalassemia intermedia or NTDT, non-transfusion dependent thalassemia. So this is a thalassemia intermedia, not a trait. This is not a trait. If you have a trait, your hemoglobin is never, your hemoglobin is somewhere around 10. This is a thalassemia intermedia. That is why this child has not received blood transfusion. He has spleen, he has liver, he has jaundice. You can see that his MCV is low. So he has a microcytic disease. So thalassemias all have microcytic disease. And your RDW is high. And what you see in the peripheral smear is nucleated RBCs. Again, the typical most finding of thalassemia major or thalassemia intermedia. So this is a thalassemia intermedia. How do you differentiate between the two conditions? You cannot differentiate by HPLC. HPLC can be similar. It is just the age of presentation. Thalassemia major presents in less than 2 years. Thalassemia intermedia presents after 2 years. Thalassemia major will have hemoglobin less than 7 in less than 2 years. And thalassemia intermedia will have usually hemoglobin more than 7 by 2 years. So, they usually present late. The HbF is elevated in both of them. And it is mainly the clinical presentation which tells you what is the diagnosis. The next question is a child with thalassemia who presents to emergency with pallor and petechial rash. He has anemia, he has leukopenia, he has thrombocytopenia. He reported cough, sore throat, subjective fever, chills 1 week back. And his bone marrow examination shows this. So you see that a hemolytic anemia child should not have pancytopenia. That is the clue here. When does a hemolytic anemia child develop a pancytopenia? So there is that, the hint is there. So you are right. This is by a parvovirus B19 infection that can lead to a aplastic crisis in these patients. They can have pancytopenia, and it's usually the organism is parvovirus, more common in sickle cell anemia patient. You need to give them extensive supportive care, IVIG, and usually these patients require good supportive care, antibiotics, blood transfusion, and and it can happen to any child with hemolytic anemia. It's just that parvovirus usually only causes pure red cell issues, but in these children can cause a severe aplastic crisis. So you need to know that, a special situation. I'll skip this one because it's similar to the previous one. We'll go on to the next question. Match the following. So please go through this. So this is an easy one. You know that ITP, everything is normal. I'm not getting answers from you. So ITP, everything is usually normal. Platelets, PT, APTT, TT, platelet will be decreased, but all the coagulations will be normal. So that is ITP. Hemophilia A will have prolonged APTT. Okay, but TT and everything will be normal. So the A is probably hemophilia. So ITP is D, you're right. And hemophilia A is A because you have prolonged APTT. Your DIC, you will have everything increased. So that's C with decreased platelets. And vitamin K deficiency can only have normal, other things normal and only a PT prolongation, or you can have a APTT also being prolonged, but platelets will usually be normal. We'll go on to the next one. A 7-year-old girl presents with a sudden onset of petechial rash and all over the body, gradually increasing in size and number. She also develops bleeding from the gums while bruising in the morning. While brushing in the morning, she is otherwise active. She had a family similar history in the past 4 years back, for which she had some oral medication. No follow-up in the past 4 years. No organomegaly, no lymph node. Isolated thrombocytopenia. So you're right, it is ITP, PT, APTT normal. What other investigations will you do in this condition? So, we usually do a immature platelet fraction. Yes, you can do a IPF, but even if you can't do a IPF, it is your more important thing that you need to do is a peripheral smear. You need to write peripheral smear. That is the most important investigation to make sure that there is nothing abnormal in that. And if you have only isolated platelets which are low and the child is otherwise well, there is no organomegaly, you don't have to do a bone marrow. Bone marrow is done only when you have other cell lines involved, a hepatosplenomegaly, a lymph node, bony pains, child is pyrexic. So things which are atypical, So or treatment options you offer. So yes, you are right. You can just observe these patients if they are not bleeding. But if they have mucosal bleeding, and if they have a lot of mucosal bleeding, usually you would like to offer some treatment. Because in the past 4 years, she was totally fine. You can just give steroids, maybe IVIG. But if the disease is chronic, we have already discussed the options for chronic ITP. So a 4-year-old male child with the history of swelling of the right elbow since morning, which is increasing in size, associated with decreased movement and pain. He also had previous history of excessive bleeding from minor cuts for which he was not evaluated. Both parents are healthy. Blood test shows normal platelets, normal PT, and a prolonged APTT. What is the diagnosis? How do you classify the severity? And the third question actually gives you the answer. It happens many times in OSCE that once you read the further questions, you are able to guess what the answer is. So prolonged APTT is due to factor 8, factor 9, factor 11, factor 12 deficiency. It can be due to von Willebrand's disease. It can be due to inhibitors in the blood. So this probably male child with bleeding, which is significant, it is most likely a hemophilia. So you need to do a factor level, factor SA, that will classify the severity, less than 1%, 1 to 5%, more than 5%, severe, moderate, mild. And the factor replacement, you all know the doses, how to calculate the doses based on the type of bleed. We need to know how much levels are raised by 1 unit per kg of factor. That is 1 in case of hemophilia A and 0.5 in case of hemophilia B. So based on that, you decide your replacement. In lower income countries, even the lower doses of factors have been found to be useful. So for joint bleed, even if you say that 20 units per kg is something that you want to use, that should be fine if it is a hemophilia A. 4-year-old female child brought to emergency, bruises, bleeding gums. No such history of bleeding in the past. History of menorrhagia in mother. 2 other siblings were normal. So maternal menorrhagia is the one which is giving the clue here. Normal hemoglobin, normal TLC, normal platelet count, PT normal, APTT normal, TT normal. What is the differential diagnosis? So when you have a bleeding child and everything is normal, what are the possibilities? So you're right, VWD is the first possibility. The other possibilities are platelet aggregation defects. You can have factor 13 deficiencies, where every evaluation is normal, but there usually you don't have a maternal menorrhagia history. Factor 13 can have umbilical bleeding at the time of birth, prolonged umbilical bleeding. The bleed is usually a little late after the trauma, and these are the common DDs for patients where all the basic evaluations are normal. Okay, so that is what this station is about. So the next is identify the cell. What is the stain used? Name few conditions with increased count of this cell. Please identify the cells. 5 more questions after this, and we'll quickly go through this in the next 10 minutes. So these are reticulocytes. You use supravital staining to stain this reticulocyte. You don't do it on a normal CBC sample. You use a special stain. You don't fix them with alcohol. You don't want the cells to die. And these are supravital live cells. Conditions are all, usual hemolytic anemias. You can mention blood loss. You can mention when there will be high amount of retics. So hereditary spherocytosis is a typical. Autoimmune hemolytic anemia is another one where your retics are high. Thalassemias actually don't have very high retics because there is ineffective erythropoiesis, so you don't get very high retics with thalassemia usually. So this child presents with skin lesions, frequent bleeds, and also history of bloody diarrhea. Hemoglobin is okay, TLC is okay, but platelets are low. What do you think is the condition? It's a rare disorder. So yes, you're right. This is a Viscot-Albrecht syndrome. So Viscot-Albrecht is a type of immunodeficiency. You can have eczema. You have microthrombocytopenia. The MPV is low. The platelets are very small in this condition, as opposed to ITP, where you have giant platelets and high MPV. This is associated with immunodeficiency and chance to develop malignancies. The treatment is a stem cell transplant. Okay, so important differential for ITP. Children are often managed as ITP, but only later they find out that this was another condition. And usual response to IVIG steroids is not much, although there is a component of autoimmunity and some children can benefit with that. So this is an 8-month-old child presenting with pallor, noticed at 3 months of age, requiring blood transfusion again and again. CBC shows anemia, normal WBC count and platelet count. Child has dysmorphic facies, bone marrow shows erythroid hypoplasia. What is the probable diagnosis? If your bone marrow has erythroid hypoplasia, then you know that it is not a hemolytic anemia. This is diamond blackfan anemia. What abnormalities do you expect in these patients? So that's right, it's DBA or PRCA. The MCV is usually high. The retics are low. Okay, the retics will be low, and the HPLC may show high HbF. This disease can have many systems that are involved. You can have many organ systems which are involved. You can have kidney problems, you can have heart defects, there is chance of developing cancer. You can have facial abnormalities, different types of abnormalities can be there in DBA patients. And, they have peculiar facies, and the treatment is usually with steroids or a bone marrow transplant, that is a stem cell transplant is usually required to correct the abnormality in these patients. Okay. So this is a 6-year-old male child who presents with pallor, bleeding gums. There's history of recurrent blood transfusion. He's found to be short. His elder sister also has a similar history, and his CBC shows pancytopenia. A special test was done from the blood sample. If you can identify this test, you can identify the condition. So you are right, this is Fanconi's anemia. This is a chromosomal breakage analysis with mitomycin C. There can be many abnormalities in these patients, and the common hematological malignancy is AML in these patients. What they often develop is a pancytopenia. They are usually initially thought to have a B12 or a folic acid deficiency because of macrocytosis. So people treat them as macrocytic anemia. They may have some improvement because everybody is deficient with iron, B12 and everything, but eventually they develop pancytopenia, aplastic anemia, and that is why they require a transplant. But they can also develop malignancy. They can have many abnormalities like capholi, microcephaly, dark skin, abnormal thumbs radius, a lot of other abnormalities like kidney, skeleton, CNS, gonadal abnormalities, and 25% can actually be totally normal. They would look normal, absolutely normal, and you will miss this. So every aplastic anemia is evaluated by a chromosomal breakage analysis. So this is a child with a large mass in the abdomen, and on examination you can see this mass, which is huge, and a CECT shows that it is arising from the kidney. So somebody has said neuroblastoma, but you see that eyes have been shown. So eyes are shown to indicate something. They are shown to indicate aniridia. So it is Wilms tumor. And please read the CECT. It shows a renal mass. So don't jump to a conclusion. And it does not cross the midline. Neuroblastoma is the one which usually crosses the midline. But in India, even Wilms tumor can be very huge, late presentation, but generally don't cross the midline. So WAGR syndrome, Beckwith-Wiedemann syndrome, it's something that you should know. Dennis-Drash syndrome, these are associated with Wilms tumor. Aniridia is giving you a hint that this is a Wilms tumor. So the last question is a 10-year-old male child presenting with swelling over the left side of the neck since 2 months. Fever, night sweats. A true cut biopsy of the neck was done. And these are what cells and what is the diagnosis. So they are Reed-Sternberg cells, the owl eye-like appearance. Sorry. And the diagnosis is Hodgkin lymphoma. And you need to know the staging system and the 4 drugs that are used. Would anybody like to say what are the drugs used? What is the staging system? Ann Arbor staging system, you're right. And the drugs used are ABVD commonly. So bleomycin, adriamycin, bleomycin, vinblastine, dacarbazine, the common drugs used to treat Hodgkin lymphoma. Very good outcome. More than 90% are cured, especially if they present early. So on that note, I would like to thank you on behalf of Pediatric Hemonc Unit, Sir Gangaram Hospital. I hope you enjoyed the OSCE. If you have any feedback, please feel free to contact us. we can help you with any more questions or any difficulties that you have in pediatric hemonc related questions. And good luck for your exams and good luck with your preparation. I hope you enjoyed it.